So I'm going to take a similar strategy for my presentation to what Kim did and bring you something that's new and still sort of unfolding in the hopes of receiving some feedback. And also because in the long process of conceptualizing this project, I talked about it with a number of folks from this group and really benefited from your suggestions and why don't you check this out and how about this theory and that kind of thing. So wanted to show you where it went. So I'm from the Department of Family Medicine, and if you don't know anything about family medicine, you probably do know that people are having a hard time finding a family doctor these days. In Ontario, we're not so bad. I think about 87% of Ontarians have a regular primary care provider, but it is very tough across the country. And just because you are attached or are rostered with a family doctor doesn't mean that you have access to that person's care when you need it. It might take a few days. They might not have an appointment, that fits with your work schedule, all of this kind of stuff. And so in my department these days, this is like an animating problem that structures everything that we are thinking of and everything that we do in our education and in our research. And this project is no exception. So one of the things that, if you're not in family medicine and spending all your time thinking and talking about this challenge of primary care access, you might not know is that we actually have more family doctors per Canadian than we have ever had in the history of the country. But we still have this crisis in access, both in terms of not having a provider and in terms of having lower access to same day to next day or to after hours care than other comparable countries. So why do we have this now when we have more doctors than ever before? Well, one of the reasons is that fewer of our family physicians are providing comprehensive care. So fewer of the people who are qualified as family doctors are opening a clinic in the community and are seeing babies and kids and adults and seniors, the whole spate, doing the kind of work that you think of when you think of a family doctor. Instead, they've moved into hospitalist careers. They are staffing emergency rooms. They're doing sports medicine. They're doing anesthetics. They're doing cosmetic stuff. Like they've taken their medical degree and they've moved into a focused area of practice. And this problem is likely to get worse because we see younger physicians who graduated in the last 5 years, moving into this type of focused practice at much higher rates than physicians who've come before them. One potential explanation for this move is that they're trying to get away from a certain part of the work of a family doctor, and that is administrative or paperwork, the type of work that they do when they're not face-to-face with you in the exam room. And there's a little bit of research on this. Like we did a study a couple years ago that we thought was going to be about how do we teach our resident physicians how to manage this type of work during their education so that when they get out into practice, they can structure their practice in a way that feels sustainable to them and that's efficient. And we were not intending to ask them, but they just told us without being asked, yeah, I'm not going to do that kind of work because I don't want to deal with this admin work. I'm not going to open a comprehensive practice because I don't want to do this. And so that project that ended up started trying to be how do we optimize this educationally ended up being, oh God, like we need to figure this out on maybe a systemic level because educational optimization, teaching people how to deal with this is like maybe a bit of a Band-Aid solution. And so I'll give you an idea. When I'm talking about admin work, when I'm talking about paperwork, or we call it indirect patient care activities, these are the kinds of things that are going on. So we know that for every hour a family physician spends seeing patients in their clinic, they're going to spend another hour doing the paperwork that's associated with that visit. And so here is a little table of the type of activities that might include. It's all of the documentation in the chart. It's any kind of prescription refill. If you need to be referred to a specialist, dealing with the documentation that provokes that referral and that also follows that referral. If you are ever hospitalized, your family doctor will receive every single thing that's written in your chart as the clerk writes it and submits it, as the junior resident edits it, as the senior resident edits it. That all ends up in the inbox of your family doctor. And that family doctor is legally responsible for reading it, for knowing what has happened during your hospital stay. And so there is this sort of an escalating amount of admin work that results in the family doctor being situated as the hub of the healthcare system, where everything that you do in the healthcare system is mediated by your family doctor, ends up coming back to them, even when you as a patient maybe don't realize that that's happening because you think, hey, I was, hospitalized to get my gallbladder out and they dealt with it and then I went home and everything's fine. Your family doctor probably got 50 separate correspondences about that short surgery. So as a result, we do know, we've studied health admin data to see that the volume of care processes, which is just another way of saying things that doctor had to do, per visit has risen over the last 12 years, as has the number of hours spent on admin work. And what one group calculated that Canadian physicians are spending the equivalent of 55.5 million patient visits per year on unnecessary, they categorize things as necessary and unnecessary as controversial perhaps, but 55 million patient visits just doing paperwork. Okay, so what did we propose to do? So this study has been funded. This study's been funded by CIHR, and we've done the first stage of it, but we've got lots left to go. So we wanted to describe the experiences and the aspirations of family physicians and the specialists that they work with in relation to two aspects of admin work. The referral process, so that sort of hub and spoke, I'm going to send you to a specialist physician or a rehab provider or whomever, and then managing the inbox, all of the things that come into the electronic medical record, the investigations, the blood work, the prescription refills, the documentation, managing all of that. And we wanted to characterize the intricacies of those two processes to identify challenges and redundancies, as well as different strategies that have been developed both on an individual level, because almost every professional has their own way of working, their own way of trying to make this better for themselves, but also on a practice and a systems level. And then ideally hoping to propose some strategies to improve the efficiency of this work. So the part that we've done so far is two systematic reviews. We completed a systematic review on family physician or general practitioner perspectives on this inbox work and on the referral work. And just one key finding from each, we learned through the 55 included studies about managing the inbox that family physicians find this work to be overwhelming, and it's overwhelming because of these sort of fragmented and incompatible technical systems where they always have to switching between different systems, logging into one, logging out of the other one, printing something, faxing it, coming back, scanning it into the EMR. Like, it's just sort of this mismatch of systems which exacerbates the admin load. And that they perceive that they're spending so much time on this. And this work is complex. It's cognitively challenging. Like, it's often legally their responsibility to do and to do well. But because they're spending so much time on this, they're worried that it's jeopardizing patient safety. They're perceiving that it is impacting their ability to care for their patients. And as a result, it is lowering their job satisfaction and increasing their stress level. Our one key finding about the referral process is that we've actually set up family physicians in a really efficient role. So we've designed this healthcare system where the family doctor is charged with triaging the resources, allocating the resources, so deciding who needs that more expensive specialist care, who can be dealt with in the community, and using their medical expertise to make that decision about resource allocation. But because of the volume of work that is involved in not just making this decision, but identifying a specialist who is going to see this patient, who has availability, who is willing, locating their specialized form that they want to be filled out for every referral, writing the letter, attaching the investigations, filling out. Sometimes these forms are like 7 pages long with hundreds of checkboxes that need to be gone through, sending it, following up periodically to make sure the patient actually got an appointment. Did they go to the appointment? What's happening now? That this volume of work has really disabled the ability of the family physician to serve that resource allocation role effectively. What we're planning to do next is to, and we've already done the very initial part of this, we've collected a whole bunch of referral forms and we're doing a document analysis on what kinds of information and work are these forms asking family physicians to do, and how does that correspond to the regulatory requirements for those forms, because every province does have requirements about what these forms should include. Then we plan to do a bit of a think aloud protocol of having family doctors, as they're working through their inbox, talk about, okay, I've seen 17 chart updates for one patient who's hospitalized. It looks like there's not really any change, but I need to click through them to make sure that there's not something here, like that kind of a think aloud process. And then maybe some observation of them working in their inbox. And then later on, probably we'll use a grounded theory approach to interview some physicians to understand not just the gaps and the pain points and the efficiencies that we identified in the first two studies, but also how are they making decisions about their practice in relation to this type of work? Because we see these signals, especially in the health admin data, that there is a wave of family physicians who are deciding that they don't want to provide comprehensive care because of the amount and the type of this admin work. But I would like to generate some more evidence about this, because now it's just sort of like a series of signals that we're seeing across different studies. And that's it.